Hi everyone, in this recording we will discuss antidiuretic hormone, also known as arginine vasopressin. So where is it coming from? You probably recall from endocrinology is that you have the hypophysis here, the anterior hypophysis or the anterior pituitary, and the neural hypophysis, which is the posterior pituitary. It's not really coming from there. It's a hypothalamic hormone because the neurons themselves, they are situated in the hypothalamus, and the secretory vesicles, the secretion here will just accumulate inside the posterior pituitary. So what stimulates the release? So just recall that it's a hypothalamic hormone. And what increases the release of, and now that we know where it's coming from, let's talk about the stimulation of antidiuretic hormone. If there is an increase in plasma osmolality, and that's a very sensitive response. Any increase in the plasma osmolality will result in an increase in antidiuretic hormone because it retains water and a little bit of salt, so it expands the volume. And so a drop in the volume, so hypovolemia. It can be true due to hemorrhage, and it can be false because of the movement, or what we call the effective volume. So there is a movement of the fluid from the blood into the interstitium, and then your body thinks that you don't have enough volume, so it allows you to retain more. So any situation where the volume is actually lost because of dehydration, because of hemorrhage, because of leaking of the fluid into the interstitium, all of that is going to also increase the antidiuretic hormone. We're talking here about the blood, of course. And what other mechanisms? Thirst receptors. And dry mouth through the trigeminal nerve that will go and will stimulate directly the hypothalamus, and our friend, the hormone that we talked a lot about, which is angiotensin II. It also stimulates the release of arginine vasopressin from the hypothalamus. There are also abnormal situations, and I will color code it here. These are physiological, the ones that we talked about here, but we also have pathological situations where there is CNS trauma or infection. There is also ectopic release. That means a release of antidiuretic hormone from a place that was not intended to give, and that happens in cancer. So, for example, in small cell lung cancer, we see an increase in antidiuretic hormone because these cells have neuroendocrine functions, and they can secrete antidiuretic hormone. Similarly, infection, pneumonia, cystic fibrosis, and other situations in the lungs can result in also an increase in antidiuretic hormone, but that's again pathological. And then we have certain drugs like morphine, ecstasy. They are impacting the central nervous system, and then the central nervous system will release the antidiuretic hormone. But these guys here, they are pathological situations. These will be very important when we discuss an unusually high or abnormally high antidiuretic hormone situation we call syndrome of inappropriate antidiuretic hormone, or SIADH. Okay, so we understand now what are the things that release the stimulation, how antidiuretic hormone gets stimulated. Well, now we will talk about what does it do. Outside the kidney, it causes vasoconstriction. Outside the kidney, well, almost in the kidney, but it has nothing to do with the tubular reabsorption. It causes constriction of the afferent arteriole. And so the vasoconstriction we have here, it elevates the blood pressure. Remember, one of the problems we have was that the fact that we did not we have hypovolemia, so that kind of corrects it, at least functionally. And then the constriction of the afferent arteriole, we agreed that this will lower the GFR, and therefore we are preserving the volume. But on the tubular reabsorption, so these are not too important functions and we're not too big of functions, but the more important functions are on the tubular reabsorption. It acts on both salt and water intake, and it starts all the way here at the thick ascending limb, and then it goes to the distal convoluted tubule, and it goes into the collecting duct. So it acts over here on the NKCC. It increases the activity of the NKCC, so it's absorbing salt. It acts on DCT1 by increasing NCC. It also acts here by increasing ENaC, also at the collecting duct. It will increase the ENaC. And all of that, you will say, well, wait a second, it's increasing the salt reabsorption. What's going on? I thought it's supposed to take in water. Yes, in the collecting duct, it's gonna activate, and we'll talk about the process of activating aquaporin 2, and that will result in the absorption of water, and water absorption exceeds the salt absorption. So even though we are activating several sodium channels here and sodium chloride channels, the main goal is really to retain water. So aquaporin 2 will be activated, and we will see how that takes place with the stimulation with antidiuretic hormone. Also, all the way here at the inner medulla, we will have transporters for urea, and those are called UTA1 and UTA3. So these urea transporters will allow some of the filtered urea that still continued all the way in the collecting duct to get back into the interstitium. Because urea has osmolality, its own osmolality, it's going to increase the water reabsorption from the descending limb that are situated in the medulla and the juxtamedullary nephron, and therefore this urea here is helping you to concentrate the urine further. And the absence of antidiuretic hormone action or the absence of urea, for example, if someone has a low protein diet, will have a problem in accumulating the urea here, which will allow the dragging of the water from the surrounding tubules, particularly the thin descending limb. So these are the channel transporters that will be regulated by antidiuretic hormone. But let's talk a little bit about the mechanism in the principal cells and how those are this actually takes place. So this is the luminal side, and this here would be your interstitial side. And the receptor is of course present at the interstitial or the basolateral side, and when it binds to antidiuretic hormone, it activates protein kinase A, it activates adenylate cyclase, and so it results in an increase in cyclic AMP. And cyclic AMP will activate cyclic AMP dependent kinases, and it will result in two things. It will result in that the secretory vesicles that did have the aquaporin in them, it will translocate into the surface. So that's faster than making from a scratch aquaporin 2, because that will take a while. Although long-term antidiuretic hormone secretion will result in increases the mRNA that will get transcribed, that will get translated into aquaporin. But we want an immediate action here. and that will be the translocation of those vesicles, so therefore you will have more aquaporin on the surface. Also, it will result in phosphorylation of the aquaporin, make them more efficient in transporting water. Water will come in passively from the filtrate into the cytoplasm once you open that because of the osmolality, and on the other side you have aquaporins that are not regulated by antidiuretic hormone, and the water will be absorbed towards the interstitium and from the interstitium to the blood. So what else can stimulate this adenylate cyclase and can stimulate the production or at least the expression of aquaporin? So aquaporin are also increased by aldosterone and angiotensin, although not at the same level. So aldosterone and angiotensin will take more salt than water, whereas antidiuretic hormone takes more water than salt. Get it? And so it gives a little bit of an increase. Also, if we have high osmolality here, that in itself, that in itself can increase, just the increase in the osmolality can also increase the presence of aquaporin on the apical membrane. Makes sense? Okay. So these are the functions of antidiuretic hormone. You can see here that we're not only dealing with reabsorption of water, but we're also reabsorbing salt as well. Gets us to abnormalities. So we have diabetes insipidus, and in diabetes insipidus, diabetes meaning excessive urination. So it doesn't mean someone has high sugar, or so we often use the term diabetic as indicative of the sugar situation, but it's really the urine, the amount of urine that we have. And so diabetes insipidus, we don't have enough secretion of antidiuretic hormone, and it can be central. That means the hypothalamus is failing to secrete the antidiuretic hormone, so for some reason, or so that we call central. If we don't have antidiuretic hormone, we call that central. But it can be also nephrogenic, so a problem with the kidney. So we do have a lot of antidiuretic hormone in the blood, but the receptors are not there, or the function is not there. So it can be what we call nephrogenic, and that can be in renal failure and other situations, for example with chronic lithium injection. And somehow the board likes to talk about lithium, and the way it works is that lithium will get in the cell with the ENaC. You remember the ENaC channel, and lithium can masquerade itself as sodium, so you end up with lithium accumulating inside the cell, and there is no way for it to get out. And by accumulating inside the cell, it will inhibit the enzyme that causes the cells to make cyclic AMP. It's called adenylate cyclase or adenylyl cyclase, and that will reduce the cyclic AMP. And so therefore, even though the antidiuretic hormone is binding to its receptor, but you are disrupting the cyclic AMP synthesis with lithium. And remember that it is coming through the ENaC. And why is that important? Because if you want to reduce the acute toxicity, if someone is on lithium and you want to stop the kidney from accumulating lithium, you give amiloride, which we know that it inhibits the ENaC channels. That's the importance from kidney perspective. Gestational, so during pregnancy, The placenta makes an enzyme called vasopressinase, and that's an enzyme that will break up vasopressin, which is antidiuretic hormone, and so therefore there is accumulation also, there is a reduced antidiuretic hormone when it comes to gestation. Okay. Luckily, it's matched with the reduced threshold, and we're going to study that when we get into the water balance. Okay, so what is the clinical scenario here? Well, we're not able to concentrate urine, so obviously there is polyuria and polydipsia. And it depends on whether it's central or not. If it's central and you give the patient vasopressin, then it corrects the situation, whereas if it's nephrogenic and the receptors are not there or not functioning, then that is not going to correct the situation. So you can also diagnose whether it is central or nephrogenic based on the response of the patient to vasopressin, to antidiuretic hormone treatment. Obviously, there will be hypovolemia and thirst sensation and all of that. Sounds good? And so that's the clinical scenario we have with diabetes insipidus. Gets us to the final point here, which is the syndrome of inappropriate antidiuretic hormone, or SIADH. So we have excessive production. That can be central nervous system has infection, trauma, tumor. All of that is going to impact the central nervous system to make more antidiuretic hormone. Also, drugs that impact the central nervous system, like morphine, like ecstasy, and other hormones, other drugs that impact the central nervous system are known to increase the production of antidiuretic hormone. It can be also that the antidiuretic hormone is made ectopically, like we said earlier, from a tumor. So, for example, small cell lung cancer, it does produce antidiuretic hormone, and so that's an ectopic production. It can be also from the lung. So the lung has an issue because the lung has neuroendocrine cells that can produce antidiuretic hormone. So in case of pneumonia, in case of cystic fibrosis, in case of asthma, sometimes what we have is increased production of antidiuretic hormone. And we said earlier, the drugs that will impact the CNS, like morphine and ecstasy, they also can increase the antidiuretic hormone production. So now we have excessive antidiuretic hormone, and so you are retaining a lot of the water, and so there will be hyponatremia. Why is that? Because you're retaining more water than salt. In the acute phase, you will think that this can result in hypervolemia. It doesn't. Somehow there is a shift of the balance that we have inside the cell. The cell essentially will throw away some of its content, like phosphate, to make sure that the cells do not swell. And so it actually, if you ask any clinician, it is associated with euvolemia. And so that's an important part here when you are trying to correct SIADH. You definitely do not want to correct the hyponatremia suddenly, because if you do, the problem is, especially in the neurons, the problem is the cells, like I told you, it compensates. If the sodium goes down here and it becomes hypotonic, the cells also are kind of hypotonic to compensate, to avoid the cells from undergoing swelling. But if you give sodium, additional sodium, so it will start dragging suddenly the fluid out of the cell, because the cell is hypotonic now. And that can result in acute demyelination of the nerves and death. And so you want to make sure that in SIADH you do not correct the hyponatremia suddenly, because that can be fatal. And so what about the urine? Well, you have excessive amount of urea of antidiuretic hormone, so there will be oliguria. So oliguria, and so we have very scanty little urine production. All right, so these are the situations that can be abnormal with antidiuretic hormone. We talked about diabetes insipidus, and we also talked about SIADH. Earlier on, I shared with you where it's secreted from, what regulates antidiuretic hormone, and what are the actions of antidiuretic hormone on the tubular transporters or channels. We discussed all that. So hopefully this is a quick wrap up for the antidiuretic hormone, also known as vasopressin. One last thing, as you will study in endocrinology, vasopressin is highly similar to in structure to oxytocin, which we give a synthetic form during induction of labor called pitocin, also to reduce the postpartum hemorrhage if the uterus is not contracting well. And if we keep the pitocin drip for long, that oxytocin can start acting as if it is antidiuretic hormone. So guess what? After pitocin drip, for example, to treat postpartum hemorrhage, it's possible that the patient will develop SIADH. And so that's a side note. We'll talk about that in our clinical application. Have a great day.